Okay. Um, the reason I went back to this picture, we've already done this slide, but I'm going to talk about reabsorption and secretion, some urine production things. But when I'm talking about reabsorption and secretion, we're usually talking anywhere from the PCT, the loop of Henle, and the DCT. So once glomerular filtrate turns into tubular filtrate, and tubular filtrate is eventually going to be urine, as it moves through these yellow tubes, the capillaries that are surrounding this can reabsorb from those. Even though it's in the yellow tubes, the blood can take it back because there is this diffusion from the tubules to the capillaries. So when I say reabsorption, it's coming from the peritubular capillaries into the blood. And when I say secretion, even though the majority of the stuff gets pushed out at the glomerulus, if for some reason the blood wants to get rid of something or exchange for something, it can still leave the blood at the capillary and enter the tubules. So the body still has this whole chance to either reclaim something or secrete something. So as I talk about that, that's the area I'm talking about. And so these are things, again, I mentioned yesterday that the body usually wants to reabsorb. And sodium potassium, hopefully you've gone over the sodium potassium pump when you talked in chemistry, but they like to, sodium moves one way, potassium tends to move another. So sometimes, those levels are tied together. And when we do what's called an electrolyte panel on a dog that comes in, that is what we're looking at. We're kind of looking at the level of sodium, potassium, chloride, calcium, and they tend to move. Now, sodium, being a larger molecule, it is actually pumped out and moved into the peritubular capillaries. It can also be reabsorbed at the ascending loop and the DCT. So pretty much sodium reabsorption can occur at any level there. But usually when sodium moves one way, either potassium or hydrogen and ammonium are going to move the other. So if the body needs to move one, it may move the other to move the one it wants, if that makes sense. So if we're looking at potassium and calcium, they can be reabsorbed at any level, PCT, loop, DCT. Calcium is something I'm going to talk about next when we do the endocrine system. Calcium is under the influence, obviously vitamin D, we know that, but there is PTH, which is parathyroid hormone, and calcitonin. Those are two hormones that maintain calcium homeostasis. If you're low on calcium, what it's going to do is it's going to release this parathyroid hormone, and that's going to signal the body to tell the kidney to keep calcium. So if the body is low and the body notices that calcium's about to become urine, that hormone will tell the kidney to do not urinate out the calcium. The body will reabsorb it. So it's kind of like a messenger. It's like, hey, don't pee out that calcium. We actually need it. We're low on calcium. And I will get into that calcium homeostasis in the endocrine system. It can also signal the intestines to absorb more calcium from the diet. It can also access, in extreme cases, calcium from the bones. If they're getting like no calcium in the diet, they're very deficient in calcium, it can actually withdraw calcium in the bones, which is not a situation we want. The bones need their calcium, but in these situations, it can do that. And magnesium is reabsorbed, and PTH is going to, calcium and magnesium are both under the influence of PTH. And we talk more about that next. Chloride, another one of our electrolytes, will diffuse from the tubular filtrate into the interstitial space, and it will move but it is also in relationship to sodium. So the way sodium moves other items. But one thing I want to also say is that some of the water moves by osmosis into the space in the peritubular capillaries. So basically, after sodium, glucose, amino acids, and chloride have left, water can move the other way. Now, the body may move those out to allow water, because remember, in osmosis, it also wants balance between the interstitial fluid, this fluid in the tubular filtrate, and in the blood. There's always that water balance that is occurring, but the body can kind of force the issue by moving other things. Now, secretion, when I say secretion, things are moving from the peritubular capillary. They were in the capillary and they're going to move to the tubular lumen to be secreted. But the primary place that this absorption, reabsorption happens pretty much PCT, loop, and DCT. But secretion primarily occurs in the DCT, which is, remember I said the DCT is the last stop. It's kind of like if you were getting off a train and the PCT was the first stop, the loop of Henle's the second stop. The DCT is like, unless you get off this train, you're staying on the train, if that makes sense. So after the DCT, you have the collecting duct and it's going to become urine. So this is where we want to usually get rid of the waste, the hydrogen, potassium, and ammonia. Now, potassium is good. We also don't want to have excess potassium, okay? We don't want to, and one thing I will mention, potassium has a role in muscle activity. It also has a role in cardiac function. In emergency, one of the big emergencies we see is blocked cats, or cats that cannot urinate. Sometimes, especially if it's a male cat, they have, we're going to talk about it, they have a very narrow urethra and a very narrow penis. If they have any grit or stones and it gets stuck, well, then what happens is, remember I said the kidneys are constantly making urine. They don't care that the cat can't urinate. Their job is to continually make urine. So what happens is this bladder gets bigger and bigger. And there's only a few emergencies where an owner will call and I'll talk to them and they say, should we come in? Should I bring my animal in? If it's a GDV, if I think they're describing that, if I think they're describing a blocked cat, it's a surgical emergency. And most of the time, the cat can potentially die before the bladder ruptures. But one issue is they get this high levels of potassium. We monitor potassium levels. The cats in advanced blocked state can actually come in almost comatose, laterally recumbent, hypothermic, because if the body's kidneys cannot function, it affects so many other things. And the levels of potassium affect the heart and they have arrhythmias. And it affects the calcium and the sodium and the muscle's ability to contract. And it affects their mentation because wastes build up. If they can't urinate, some of those wastes get reabsorbed, kidneys back up. It sets up, yes, and Madison, I mean, it, you know, I've had my doctor get really kind of point blank with owners because they're like, oh, and I realize it's hard for owners and what should I do? And the surgery's not cheap. But, you know, I've had a doctor say like, look, your cat can die. I came on a shift and I went over and I was doing my little rounds to come on my ER shift. And I had this cat and I saw, you know, the litter box and I was kind of thinking, but it was laterally recumbent. And I was like, oh, did you guys just unblock it and sedate it? They're like, no, we haven't done anything to it yet. I was like, this cat hasn't had sedation? And they were like, no. I mean, I could take the cat's head and like, it was like a puppet, you know, it was very, very sick, very, very sick. So, but think about all these chemicals. Now there's good things and bad things, but if the bladder cannot empty Okay, eventually urine is going to backflow, which it should never do. It should go from the kidneys to the ureters to the bladder to leave. If the bladder stretches to a certain point, what's going to happen, and this is sometimes these guys, well, they're painful because their bladder's huge, but they're also painful because what happens is it goes backwards through the ureters and it swells that kidney. Now that kidney, remember, is in a capsule, a very fibrous tissue. What happens is that kidney cannot stretch, and it's going to put pressure on the kidney in this capsule. So you just touch them up by their ribs, and it's extremely painful because their kidneys are tender. So all I'm thinking is, like, if they cannot get this out, and ammonia levels are going to cause if you have high ammonia levels in the blood, it's going to cause neurologic abnormalities. So the fact that the animal cannot urinate out the ammonia is going to back up in the blood, and that's going to cause issues with mentation. So it's, it's all kind of interconnected. So I want to also mention something here. So again, here's the tubular lumen, here is the capillary. I'm talking about stuff leaving this capillary and going towards the tubular lumen to be secreted. Some medications are also eliminated by secretion. When you guys have pharmacology, you have a whole week on pharmacokinetics, which talks about how the body uses drugs, processes drugs. The primary way, and I'm going to talk about, obviously I do anesthesia, so when I teach students about ketamine in the cat, in the dog, when you give a dog ketamine, about 50% of it is biotransformed in the liver, meaning it takes the drug and it breaks it down, it makes it inactive. About 50% is excreted by the kidney as active ketamine. So when you give a dose, when it's broken down, 50% of that drug circulating before it's excreted is still active. In a cat, when you give a cat ketamine, and a lot of clinics use ketamine is a part of a lot of anesthetic protocols, especially in cats. If you have a cat that has elevated kidney enzymes, okay, ketamine is about 80% excreted active in the kidney. Only about 20% is transformed in the liver. So 80% of the dose that you gave has to be urinated out. And when it's urinated out, it is active. So what do you think that does? If I give a cat ketamine that has some kidney disease and I give it a dose, how is that going to affect the cat's recovery from ketamine? If I know most cats recover in about an hour or two, what do you think happens to the cat that has the impaired kidney function with a dose of ketamine? Just spitball. Think about it. Well, you're going to see longer, you're going to see longer side effects. You have, you're kind of on the right track here, where if there's side effects from that medication, they could be greater. But if I know that a cat should recover in about an hour to 2 hours with normal kidneys, if the kidney can't clear the drug, then where does the drug stay? If the longer impairment or potentially overdose. A longer recovery. What it means, so ketamine, it stays in their body. If it's not being urinated out, it stays in the bloodstream. Okay? And then that blood is going to go back to the brain. It's a full circle. So what happens is that ketamine keeps going to the brain and it keeps sedating them. And so the owner calls and says, hey, you said my cat be ready in 2 hours, and Kitty's still pretty asleep. So it can extend recovery time because instead of the drug being secreted or excreted in the urine, it remains in the bloodstream. And if it's in the blood, it's available to the tissues, primarily the brain. So but you guys were definitely on the right track. I mean, I'm kind of pushing your brain to say, okay. Now, I will go over key things like this in anesthesia, and you talk about this in pharmacology, because if we're going to give it to a cat, and you can use ketamine in a cat that has kidney disease, I just lower my dose. I don't give it as high as I would to a normal cat, because I know it's probably going to have a prolonged effect. And for those of you that are in practice, my big preach with anesthesia is you can always give more. If I decide to give a weenie dose of ketamine and it doesn't work, I can give the cat some more, but I cannot take ketamine away. Once I give it, I'm stuck with my effects. So there's lots of situations I would rather go on the low end, because there's a lot of animals I cut back my dose and it's totally fine. I got away with a much lower dose. When I get into anesthesia, I have an analogy about making soup. It's like if a recipe calls for like 4 tablespoons of salt and you give it, you cannot take that soup now that salt out of the soup. Maybe if I put in 2 tablespoons, I'm like, oh, that's pretty good. I don't need 2 more tablespoons, if you see what I'm saying. So especially kidneys are going to be essential. And I'm going to tell you real quick, most of the drugs that go to the kidney have been biotransformed by the liver. The liver's kind of like taken it apart and made it inactive. It doesn't work anymore. So when the kidney is supposed to excrete it, it's excreting something that's inactive. But a drug like ketamine is excreted in its active form. So it's relying on complete excretion for those effects to go away. So not all drugs do that, but there's a few drugs that we have to keep that in mind. This is an important theory to understand. The volume of urine is basically, okay, how much tubular filtrate reaches the collecting duct, which goes to the renal pelvis. So how much fluid stays in the tubular filtrate is going to determine how much urine we have. But it is under control of 2 hormones, but I want to focus on one. I really want to focus on ADH. If you look at what the word means, anti-diuretic hormone, okay? In a normal animal, under the influence of diuretic or diuresis means to increase or force urination. If you diurese, let me put an example. If you're in, my boss might say, hey, we got to diurese this patient. I know that we're going to hook that animal up to fluids, and we're going to be pushing that animal on a high rate of fluids. And what we're doing, and sometimes when they ingest a toxin, say they ingest, an owner's medication, sometimes a dog ingests chocolate, or, there's lots of different toxins that one of the part of the treatment is to diurese them. And what we're doing is we're forcing a higher amount of fluid in the body, and we're trying to force urine to the kidney and kind of flush out the system. And hopefully we'll flush out that toxin in the urine. That's what we do by diuresing. When we give an animal a diuretic, it means that we want to force more of their body water into the urine and increase urination. We gave chemotherapy to dogs. There was this one chemotherapy agent, and I'm totally blanking. It was part of our lymphoma protocol, but it was toxic to the bladder. Sometimes it would make these dogs get what's called like a sterile cystitis. It would irritate the bladder lining when they would get this chemotherapy agent. So the dog would go home on 3 days of Lasix after chemo. So it would force the dog to produce more urine, and it would help flush out that agent from the bladder and help the dog feel better after chemo. But I always told the owners, I'm like, your dog's going to drink a lot and pee a lot. So take them, and you have to take them out all the time and give them water. We're trying to flush them out. So I said, I'm sorry, 3 days, your life's going to kind of suck because you're going to be going out with your dog multiple times, but it's to flush the bladder. So that's what diuresis means. If I'm anti-diuretic, then what the body is doing is saying, we need water. Do not make as much water, or do not put as much water in the urine, and the body will retain water. So anti-diuretic is doing the opposite. If the animal is dehydrated, the body wants to conserve body water. So what it will do is ADH is released from the pituitary gland, which we're going to talk about this next week too. It is released to the kidney, and it signals the kidney to retain body water in the bloodstream. Therefore, elevate hydration. Do you notice if you feel dehydrated or you don't drink a lot? I mean, you don't urinate as often. And that's because what's happening is the body knows you're dehydrated, and it's trying to conserve that water instead of sending it to the urine. But I will tell you, if you have an animal that is, and I'm talking about this for a reason, because I like to ask about this hormone. If you have an animal, so this is slide 27, if an animal is deficient in puppy playtime, if you can hear him in the background, he's in the way of their living room, but if you're deficient in ADH, meaning the body that cannot make as much ADH, which is in the pituitary, then you're going to get polyuria, which means what? What does polyuria mean? Exactly. Frequent urination. So, but I'm going to mention something here. It's kind of chicken and egg kind of thing. When an animal is deficient in ADH, the polyuria comes first. What's going to follow polyuria typically? If an animal is urinating all the time, what are they going to do next? Probably. If I'm peeing a lot, I'm polydipsic. I'm drinking a lot. Now, an owner sometimes notices the drinking first because they're like, oh my God, I just filled up my dog's bowl like an hour ago. He already needs more water. What's going on? And I mean, they also know they have to go out a lot, but polyuria and polydipsia go together. In this disease or in this condition, if they're deficient, the polyuria kind of comes first, and that's driving the polydipsia. But I'm going to give you an example. PUPD, you guys will hear that like 500 times while you're in school, because it's the symptom of about like 500 diseases, is PUP. So when an animal comes in PUPD, we have a lot of things to figure out. It's not like, oh, you have this. You could have all of this, and now we're going to figure out which you have. Diabetics. If an animal is diabetic, one of the first things sometimes they see is PUPD. Now, in diabetes, they have high blood sugar. High blood sugar makes the animal feel thirsty because sugar draws water to it. So not that they're really dehydrated, but it makes them feel like they need to drink. So a diabetic is polydipsic. And because they're polydipsic, they're urinating all the time. Do you see how one came before the other? So, I mean, like I said, a client's going to tell you both. But in this disease, they're urinating and it's making them thirsty. So they drink more. In diabetes, they're drinking more because they feel thirsty, then they urinate more. So again, so I want you to know, and again, we're going to talk about ADH when we do the endocrine system more. But if they're ADH deficient, that's what I'm talking about. Okay. Now, regulation of blood pressure. I'm going to type something that you need to know. Okay. When you get a blood pressure, it's like 120/70 with a mean of 65. Okay. That number to the side, which is your mean, is your average blood pressure. It takes at least a blood pressure of 60 for a mean to maintain blood flow, oxygenated blood flow to the kidneys. So if it drops below 60, then what happens is if it's going like 60, 50, 40, if we have an animal that's crashing, eventually what happens is blood from the kidney is shunted to the body starts to preserve brain, heart, and lungs. So they take the blood from the periphery and they start to bring it to the core. But what happens is if you have no blood flow to your kidney, A, you're not making urine, B, you're not sending oxygenated blood to your kidney, and all those little nephrons start to die. A little tip that I did not bring up when I told you BUN. When I talked about BUN, blood urea nitrogen, and I said that normal is like 5 to 35 or 7 to 35, something around there. An animal has to lose 75% of its nephrons before you see a change in BUN. So you could have an animal that's lost 50% of its kidney function or 50% of its nephrons are no longer functional, and it can have a normal BUN, which is one of the main tests we do to test for kidney function. I have an animal, I'm like, what's the BUN? I do anesthesia, I'm like, what are your kidney values? And your liver values, but I'm like, what's your kidney values? So when we have an older animal under anesthesia, one of the things I battle when I do anesthesia is blood pressure. Because I know under anesthesia, blood pressure is going to be lower. It's automatic. It's going to happen. I want to prevent it from dropping too low because I want to maintain pressure to the kidneys. Because if I do that, then my kidneys will function normally. Now, the kidneys have their own role. They are trying to help themselves out. So the kidneys can help try to regulate blood pressure through this. It's called the renin-angiotensin-aldosterone system. Basically, when blood pressure starts to fall, they release a hormone called renin. And it's going to split this enzyme, but I want you more to know what is the purpose. When this renin is released and splits this enzyme, it's going to increase the sodium and water that is reabsorbed back into the bloodstream. That's the key sentence there. It increases the amount of sodium and water reabsorbed. If I am an artery and I'm a tube, okay, and there's low blood pressure, and you put a bunch more sodium and water in this tube, it's going to put pressure. Do you see what I'm saying? Sodium is a large molecule. Okay, sodium's a large molecule, and sodium usually draws water to it. So a lot of times where sodium moves, water moves. By increasing the volume of sodium and water in the vessel, you automatically increase the pressure inside that vessel. Blood volume increases, so does blood pressure. Now I'm telling you, under anesthesia, the body can try to do this, but sometimes blood pressure is going to be to a point where we really cannot fix it. It's really going to be to a point where, yeah, maybe it's not going to be enough. But I'm saying in a normal everyday animal walking around, laying in your house, at your practice, whatever, there are constant fluctuations in blood pressure. Now, obviously in anesthesia, our issue is we're giving drugs that alter blood pressure because of the anesthetic agents. But in an everyday animal that is awake with no drugs on board, that maintenance of blood pressure has to be maintained. It's part of homeostasis. So again, this is kind of what happens in a normal animal every day, every moment of their day. They're maintaining that blood pressure. It's kind of why when cats come in with advanced renal failure, sometimes they're hypothermic, Sometimes they have really crappy blood pressure. Well, gee, if they have bad kidneys, do you think this part functions properly? Maybe not. So in end-stage renal disease, cats can look very, very, very ill because the kidneys are so important in maintaining a lot of homeostasis throughout the body. Okay. So everything, are there any questions about anything I've said so far about this renin system? I mean, this is a lot of physiology and understand. The people that are not in class today are really gonna, because I promise a lot of this is gonna be on the test. Okay. So that's good. Yeah, I figure you guys are pretty good about bopping in for questions. I just want to make sure because that's all kind of important to understand. That's kind of all the physiology or what happens with the, let me, hang on once. Where is, I got to go back to one thing that is not here at the end. And I think something happened to this PowerPoint, or unless I skipped over it. Let me mention one thing. I went back to slide number 6 because there is the production of hormones, mainly erythropoietin. There are prostaglandins. Prostaglandins are tissue hormones that are made in different areas by many different tissues. But I want to talk about erythropoietin. Erythropoietin is actually produced in the kidney. So most hormones are produced in true endocrine organs. The kidney is not an endocrine organ. It's a urinary organ. But it does produce erythropoietin. And erythropoietin basically helps maintain red blood cell production. Erythropoietin, red production. Do you see where the word says that? Erythropoietin. Poiesis is production. So I'm going to tell you what happens. You know red blood cells don't live forever. And maybe you talked about this in Clin Lab 1, but just indulge me for a minute. When your red blood cells die, red blood cells carry oxygen via hemoglobin. If you have a normal amount of red blood cells, you should have an adequate oxygen level. When red blood cells start to die, the body, via the homeostasis, picks up on the fact that there is maybe suboptimal oxygen, like maybe oxygen dropped a little bit. And they're like, maybe we need more red blood cells. So what happens is the kidney, the brain triggers the kidney to release erythropoietin. Now, hormones are chemical messengers that travel through the blood. So the kidney releases it, erythropoietin goes to the target tissue, which is the bone marrow. And it says, hey, bone marrow, can you make some more red blood cells? Because we're kind of low. And then the bone marrow goes, okay. And the bone marrow spits out some more red blood cells. What happens when they spit those out? Your oxygen level comes up. Erythropoietin goes, I'm good. I'm going back to my kidneys, going back to bed. Kidney reabsorbs the erythropoietin, and we're back to homeostasis. So what happens, because I've talked about renal failure, sometimes we get these old renal failure cats, you come in and you do blood work and their PCV is really, really crappy. Have you guys done PCVs yet? You're going to be doing PCVs, I think probably soon here. Okay, so a PCV is a super quick test. It tells you a lot. They're cheap. I really like PCVs. It's the percentage of red blood cells to plasma. So with how much of the blood is cells, how much of it is plasma. Now, if it's low, then, and we have a lot of plasma and you have like a little bit of red cells, then we have this issue where we don't have enough red blood cells. So when a cat comes in renal failure though, the cat didn't bleed out. The cat wasn't hit by a car and lost blood. What's happening is the cat's kidneys are not functioning properly. It is not producing, the cat is not producing erythropoietin. So what's happening is red blood cells are dying like they normally do. They're not being replaced. So anemia often accompanies renal disease or renal failure because of a failure to produce this hormone. I had an old, nice lady. She loved this cat more than life itself. This little, like 16-year-old cat in renal failure. I want to say it was like 6 or 7 pounds, kind of scrawny. That lady, we put a feeding tube in her cat because elevated BUN and that ammonia make the cat feel very sick and nauseous. They don't eat. So she had a tube. She tube fed her cat. We did 3 blood transfusions because the PCV would get so low, the cat would get very weak, and we did a blood transfusion. After about 2 blood transfusions are sometimes the max in a cat. After the 3rd transfusion reaction risks go up like tenfold. So we told her she wanted a 4th transfusion in this cat. My boss finally had to tell her, say, look, your cat's had 3 transfusions. We've had a feeding tube in for 4 months. I mean, this is end-stage renal failure. This cat should have, now I will credit this owner. She did great nursing care at home, and she was just not ready to let the cat go. So eventually did have to put the cat to sleep because the transfusion only buys us about 3, maybe 4 weeks. So each transfusion bought us a little bit more time. But I want you to understand the relationship. That cat probably has fantastic bone marrow. When the cat is not making red blood cells and we verify there is anemia, if it's kidney disease, it can be because of the deficiency in erythropoietin production. So I just wanted to make that connection. I kind of have a funny thing that I have like the big horse legs sometimes in class, and I'm like erythropoietin, and I go like knock on the bone, and I'm like, yo, hello, can you make some red blood cells? And the bone's like, fine, whatever, make some red blood cells. And I'm like, I'm out, you're good. And the bone marrow's like, okay. And it's kind of like a little bit of a funny scenario, but like I said, in that scenario, again, it's not the bone marrow's fault, but the bone marrow is, I kind of call the bone marrow dumb. It's sitting there waiting to be told what to do. Instead of just like, maybe I should make some red blood cells, it has to be told, hey, make some red blood cells. And that is erythropoietin's job, is to do that. So I'm like, yo, dude, I kind of like use the analogy, and my son's in the other room, so he might hear me, but it's kind of like taking out the trash. I mean, can he not walk by and smell it? But no, I have to be like, hey, take out the trash. Interesting. Okay, so let me talk about, we're back to structures. So here is the bladder. The kidneys would be up here. So this is only showing you the bladder, and kind of, there's 2 tubes here. So the kidneys would be up here. Urine should go from the kidney to the ureter, bladder, urethra. They extend all the way up to the kidneys. Here is the trigone. And if you think about this, kind of looks like a triangle, trigone, triangle. This is the neck of the bladder. If this is a head, kind of looks like an alien head, and these are like antenna. But if this is a head, this is the neck. And at the neck is where we find the trigone. Do you see how these ureters come in? And basically, this is a VD image. So the ureters actually enter the top of the bladder. Okay, and then we've got the trigone here, and we've got the openings. And then the urethra is going to extend out. It is a continuation of the renal pelvis. So the renal pelvis narrows to the ureters. It's all connected. And it comes out of the hilus. Out of the hilus, you have the renal artery, the renal vein, and the ureter. It does have a fibrous layer. There is muscle in the ureter. It's a tiny little tube, but urine is propelled via peristalsis. So there's a wave-like motion that takes the urine from the kidney. It's not just gravity. I mean, the kidneys are up here and the bladder is down here. So it's easier for it to flow. And remember, urine should never go backwards. The only time urine goes backwards is if an animal is blocked via a stone. We had a dog that had a really bad prostate tumor I haven't had to do much emergency radiation when I was in oncology. We got a call that we had to get this beagle in, and it was just like drip, drip. And when we felt his abdomen, his bladder was like a rock. So the prostate wraps around the urethra. And because this dog had a large tumor, it was compressing, and you cannot really do surgery there because it's under the pelvis. So it's a very bad location. So the only thing we did a two radiation in one day plan, which isn't usually done. But we radiated him first thing in the morning, and then we stayed till 8 o'clock that night, and we radiated him one more time in the evening, high dose radiation. We got some shrinkage. It wasn't complete. And he could urinate a little bit. But that's the only time where urine would go backwards, and it can swell the ureters and it can swell the kidneys. But they are stretchable. So that muscle, that fibrous tissue, it all will accommodate more urine, less urine. Now what happens typically is they come in, it says at an oblique, which is an angle, okay? If this is my bladder, they're not like this, and they're not like this. They're coming in at an angle. Now, the urinary bladder is very thick. It has muscle. When it is empty, it kind of looks like a shriveled up, like giant raisin with all the wrinkles. And then when it stretches, you can see that it gets very flat, and this is full of urine. But what happens is the urine comes up to the very top, and it puts a little bit of pressure right here, and it closes off the ureters. So this urine shouldn't be able to go backwards unless it was under super high pressure. But what's going to happen is it's going to come up and push here, and it's going to close that off. So temporarily, when the bladder is full, there is a stoppage of urine flow from the kidney. It doesn't mean that the kidney's not making more urine. It just means temporarily it's not filling up. So it kind of closes that off. Excuse me one second. Okay, sorry, puppy question. What? Okay. Um, okay, so there we go. We've got the kidneys, the urinary, the bladder. It will store urine, that's its primary function, and it'll stretch and stretch and stretch, and then periodically will contract, and it is muscular. Really, how big and where it is, normally the bladder is the very caudal part of the abdomen. You will be trained to, one of the skills you do is called a cystocentesis, and you have to feel the bladder, hold it, and then we take a needle or a syringe, and we'll actually inject the needle. I know this sounds weird if you've never seen it or heard of it, but you put a needle into the bladder. You're like, you put a needle in the animal to draw blood. You put a needle in the bladder. Sometimes we need to get urine more sterilely. Sometimes people catch urine in a bowl for a urine sample, but that's passed through the urethra in through the vulva, and it can carry debris if we want a sterile sample, you'll put a needle in the bladder and collect the urine directly from the bladder. But if you're feeling up cranially in the abdomen, like towards the middle of the abdomen, what I usually do is I try to push the bladder back against the pelvis, and that prevents it from sliding forward. And then you can feel it. Kind of feels like a filled up balloon. Most cats, it's hard to sometimes feel in a dog unless they're like, 20, 30 pounds and under, unless it's really full. But in a cat, you can reach in and you'll feel this kind of like firm balloon. It kind of sometimes slips between your hands, goes boop, boop, kind of goes back and forth. But the lining is a transitional epithelium. If you remember, I talked about transitional cell carcinoma in class. If there's bladder cancer, it's named for those cells that are present. But the reason it's transitional epithelium is, remember, when the bladder stretches, you don't want the cells that are making up the bladder to kind of come apart. So they are designed to allow for stretching without losing their integrity. So transitional epithelium allows for like the expansion and contraction without coming apart. Now, the muscle in the bladder is called the detrusor muscle. When urine is detected, it's going to contract that muscle, and that's what squeezes. The detrusor is involuntary. Okay, so when the bladder, I think we can all say, I mostly talk about dogs and cats, but you all of a sudden feel the urge like you gotta go to the bathroom. What's happening is your detrusor is starting to squeeze the bladder, and you're like, I gotta go, but you don't go because you have control and the animal has control of the sphincter, which is around the neck of the bladder. So right at that neck, it can hold the sphincter till a bathroom is found. Now, we all know dogs and cats have that different, like right now, my puppy has very little control of this whole process. He'll pee like yesterday, I want to say it was like 3 times in 20 minutes or something. I was like, dude. But he's got a tiny little bladder. He drinks a little bit of water, it goes, fill up, close. So it's supposed to collect urine because it's just constantly being produced, store it, and release it. The process, which urination is called micturition, so micturition is actually urinating, is once it accumulates, you're going to get that muscle contraction, the sphincter is going to hold it. Now, the last thing I want to mention, and then I'll have to talk about the other stuff on Monday, is bladder constantly gets urine. There are stretch receptors. If you've heard me, I've talked about stretch receptors in the lungs. I've talked about stretch receptors in the stomach. Any organ that is like hollow or lungs that are expanding and contracting, basically there's a receptor. And as the bladder gets big, all of a sudden it goes beep, 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 beep. It's like we're stretched. I'm a receptor and I'm telling the brain we are stretched to capacity. And it reaches kind of like a point. And then what happens is the brain is going to initiate the spinal reflex. So there is a nerve, comes down, sends a signal to the detrusor muscle. The detrusor is a smooth muscle, contracts, and then the animal is going to relax the sphincter when they reach the grass or you reach the bathroom or whatever. The issue that we have is, this sphincter is voluntary. The more urine there is, the more pressure, it's going to eventually relax. But what we have an issue of, if you see an animal in practice, like a dachshund, they blow a disc on their back. A lot of times they've got a disc issue. And somewhere along that spinal cord, if any of those nerves that are going to the bladder, if they have a disc and it puts pressure on a nerve, it can impede that nerve's ability to send the signal appropriately. So dogs with like back fractures, dogs with disc disease, sometimes dogs with like a nerve injury. A lot of times these back dogs or these dachshunds, will get these really full bladders, but they cannot urinate on their own. They can't either control the sphincter, or the detursor muscle isn't sending the signal. So a lot of these dogs, we have to express their bladder manually, meaning we have to squeeze it. And you'll sometimes feel these dogs and it's like big like a balloon. But they do not, because of the nerve impairment, and it may be sending the signal to, usually it's sending the signal not like to the brain, but sending the signal from the brain to the bladder to initiate that contraction. And I mean, as a surgery tech, I was kind of upfront with owners to say, like, we're going to do this surgery, this back surgery on your dog for this disc, but there's going to be a period of time. It's kind of unpredictable when that's going to come back. Kind of depends on how bad the disc, when we got the dog. But are you willing to express your dog's bladder? Are you willing to put a potty pad there? And sometimes you have to squeeze. I've had sometimes my fist on their abdomen pushing, believe it or not, because my hands have gotten weak over time. Depending on the size of the dog, I used to be able to just reach in there and like push. But sometimes that sphincter is locked down and you'll see a dog and I have to kind of push. And not every owner can do that. So, you know, if they're going to go through with the surgery, I'm like, you got to be willing to do the aftercare. So I'm going to stop there, just so you can get to your other class. Does anyone have any questions? I think I put in the email for the homework. You know, this section's a little smaller. So if the homework can be due on Monday and we can do a quiz on this Tuesday, we can move on to the endocrine system. That would be my goal. So are there any questions? Okay. Well, I will convert this and send this out a little bit later. And everybody have a good weekend. Okay, yes, Sean, no, that's totally fine. You had kennel.
And it's been messy.
It's been awful. Those new dogs, they like to